Hello, everybody. Welcome in. We'll be getting started in about 1 minute or two. Thanks. Okay, we're going to go ahead and get started. And as you guys are coming in or as we're going through the presentation, if you have any questions or anything, you can just put it in the chat box. I have Kaylee that's monitoring the chat box for me, just in case you have any questions or need any clarifications. This is Granite Peak's Clinical Corner. And so we do a brief clinical corner about clinical updates, regulatory updates, different systems um, of things once a month for 30 minutes. And so this month we're doing the regulatory updates, and it's a overview on all the regulatory updates that came out recently. Um, and then we have some more detailed information on each F tag, including videos and suggestions for implementation. If anyone's interested, you can reach out to Kaylee or myself afterwards. So we can arrange a time for training for you guys on any one of the tags that we have to offer. So with that being said, I'm going to go ahead and get started. And so, like I said, these changes are going to be implemented. Originally, it was February, but they've moved that up to March. The changes are also being incorporated into the new version of the Surveyor software, and they've already been trained on that. There have been updates to the critical element pathway, and CMS is also updating their associated forms for each tag, as well as associated frameworks of reference. So surveyors, like I said, will begin using the guidance in March. And so I'm glad that we're able to get this overview out and more detailed information on any tag. If you guys want that, feel free to reach out to myself or Kaylee. So the first thing I'm going to go over are that the good news, right? Some of the F tags have been removed. And so those F tags that have been removed from the state operation manual are F622, transfer and discharge requirements, 623, notice requirements before transfer discharge, 624, preparation for safe orderly transfer discharge, 625, bed hold policy, 626, permitting residents to return to the facility, 660, discharge planning process, 661, discharge summary, and 758, free from unnecessary psychotropic medications. I say removed, but they never take any of the regulations away. They just put them in a different tag. So there are some new F tags, and there's three of them. The first one is 627, inappropriate transfer and discharge. And most of those tag numbers that I just read reference the transfer discharge. And so most of the previous regulatory compliance information is transferred over to 627. And if it's not in 627, then it's in the second new F tag, F628, transfer and discharge process. And the third and final new F tag is F887, COVID-19 immunization. So I think we all saw that one coming as well. Each new F tag also is associated with significant guidance that the facility should follow. In addition to those F tags that have been removed or information that's been transferred to the new F tags, there are also F tags with significant changes. Those F tags with the significant changes are the ones that I was referring to, that Granite Peak has guidance for each video, audit tools, and education based on how to implement the new guidance. So again, if you're interested, just reach out. The first tag with significant changes, F605. 620, 627, 628, F641, 658, 677, 697, 757, 841, 867, 880, 887, and 918. So I'm going to go over briefly after I go over the minor changes with some of the other tags, what that looks like with the significant changes. Like I just said, the F tags with minor changes include F637, and some of these minor changes are just language, rearranging a sentence or two, and some of them have some updated information. So F637, comprehensive assessment after a significant change. And so this is all related to coding ADL physical functioning. And so there's just a couple of sentences regarding independent setup, cleanup assistance, partial, moderate assist, and coding as far as that goes. The next F tag with minor language changes is F678, and that's for CPR. And those minor changes include CPR provider whose training includes hands-on session, either in a physical or virtual instructor-led setting in accordance with accepted national standards. There's some other language regarding CPR, but that's the main sentence that comes out of those changes. In addition is 700 for bed rails, 731 regarding they added the waiver of requirement to provide licensed nurses and a registered nurse on a 24-hour basis. So that was the change for 731. 732, staffing. The only thing that was changed for that is adding the word staff to the information. So in a prominent place, readily accessible to residents, visitors, and staff. And then also the word staff was added to the guidance. The information should be displayed in a prominent place that is readily accessible to residents, staff, and visitors. So the only thing that changed was that word staff. And then 744, treatment and services for dementia. It added the unnecessary medications, chemical restraints, and psychotropic meds reference to the dementia tag. The next thing that changed is psychosocial outcome severity guide. So we saw that there was a psychosocial severity grid that the surveyors can look at and access when they're trying to determine scope and severity. And now they also have a psychosocial outcome severity guide. And I would just make sure that you guys are familiar with what the guide is and how it should be applied. And so in summary, when they're interviewing residents, if it's somebody who can't talk, they can't get a hold of the family, then they would defer to the reasonable person concept. And then it goes over, ways to apply the reasonable person concept. A lot of these changes in order to tackle and make sure that your facility is in compliance with everything, it would be my recommendation to make sure that you review the changes, receive detailed training on each one of the tags. I believe it's 14 overall that had significant changes. Become familiar with the long-term care pathway and the psychosocial outcome severity grid. It sounds like they're going to be applying that more frequently than what they had previously. And also something else that you guys will need to consider is, have your policy and procedures been updated with the new information? Are you ready for survey when these changes go into effect? So looking at the policy and procedure, making sure that things are still current. Do they reflect the new requirements? Do they reflect what's actually going on at the facility? Are the resources needed to follow the policy and procedures available? So if you have forms that your staff member are using, did you complete the required education so all of your staff understand the new regulations as well? I think that some of the biggest piece sometimes is making sure that all of the new information for the updated regulation trickles down to our CNAs, our housekeepers, everybody in the facility should be aware and versed on all of the updated policies and procedures. And then making sure that the staff are informed about any changes that you've made to the policy and procedures, which would also mean that they, need the education for the updated regulations as well. You also want to make sure that you're doing a compliance check once you do make the changes for the new regulations that came out. Once you update your policy and procedure, making sure that, you have an audit, that everyone's doing, completing the process in accordance with your policy and procedure, as well as, a great way to make sure that you're in compliance is a mock survey too. Having that outside set of eyes coming into the facility, making sure that these changes have been made, that your tools have been audited appropriately and that they make sense, and any forms that you're using are following the regulatory guidelines, like I said. Also, they have the critical element pathway, so use that as an audit tool. Feel free. A lot of times, that's what the surveyors use when they go into the facility. I know that I used it when I was a surveyor. I'm sure Kaylee did too. And so we just want to make sure that if they have the tools, they're out there and published, just use the same tools that they're using as well. So lots of information with these changes. So I'm just going to go over briefly because, like I said, this is just a higher level overview in our 30 minutes that we have. I'm just going to go over some of the regulatory changes for the tags that I talked about that were changed in a big way. One of the larger tags that changed was F605, the right to be free from chemical restraints. There is a ton of information regarding GDRs, regarding your meetings, regarding the intent of the requirement. And so I would recommend education probably more than once because there's so many different components for this. They go into new definitions, updated definitions of unnecessary drugs. They go into, dosing being in excessive dosing. So for instance, a resident is on 2 antidepressant medications. They will be investigating those as well. Also looking at psychotropic medications based on comprehensive assessment of residents. So F605 is very detailed. It goes over what does it mean to have an unnecessary medication. Also, it refers to your pharmacist and making sure that the pharmacist is catching any of the irregularities and that that information is being shared with the providers so that they can update or change what they need to, or make sure that they are, if they choose not to, that you have really good documentation surrounding why, because it's not a standard of practice for somebody to be on the same classification of medication. It looks like an excessive dose. And so and I know we see this sometimes, I'm just using the antidepressant. If you have residents that are on 2 antidepressants, you really want to make sure you have good documentation surrounding why that is. And that should come from the provider as well. And the staff should be able to speak to that. They also discuss different definitions for indication of use. They refer to the anticholinergic side effects, behavioral interventions, chemical restraints, identification and indications of distress in residents, neuroleptic syndrome, gradual dose reduction and what that looks like, and some of the major side effects when you have a tramadol and a psychotropic medication like serotonin syndrome and tardive dyskinesia as well. So F605 is one of the larger ones, probably one of the ones I would first tackle. in the facility to make sure that number one, you understand all of the new guidance that came out. Number two, making sure that policies and procedures are in place that match the new guidance. Number three, making sure that they're implemented. And number four, validating that the way the facility decided to implement is working out effectively and it's in accordance with the new regulation. That is F605. The next one is F627. And like I said, all of the transfer discharge requirements stuff, they say F tag removed, but most of the information is in the two discharge tags. So F627 is called inappropriate discharge. And so it refers to what is an inappropriate discharge and what that looks like. So discharge based on the inability to meet the resident's needs, but there's no evidence of facility attempts to meet the resident needs or no evidence of an assessment at the time of the discharge indicating what needs cannot be met. So that's just one sentence of the new guidance that came out. And they're looking at something like this if you are choosing to discharge a resident from one level of care to the same level of care. And why is that happening? Especially if the resident is not in agreement, right? So lots of information. Some of it you're familiar with because they came from the other tag. So, safe and orderly discharges, making sure that we are offering the appeals and that we are following the appeal process. It says here surveyors cannot cite noncompliance exclusively based on the ruling of an appeal, but must work through the investigation. So if you have an appeal process, you want to make sure that that's being followed and that it's being honored as well. Part of their investigative procedure includes referencing the ombudsman and getting the ombudsman involved. So if you had a situation like that at your center, you want to get your ombudsman involved up front. So that way, you know that the surveyors are going to already contact the ombudsman anyway. So you want to make sure that they're involved. And you're working with your ombudsman based on whatever situation is happening in your facility. It also updates level 4 immediate jeopardy. And so some of the changes in the immediate jeopardy is a facility discharged a resident on the basis that the resident's health had improved so that the resident no longer needed the services provided by the facility. That was the sentence that was changed for that. And then in addition, they added creating an inappropriate discharge for this resident, which did not meet her health needs. So some of the language for the immediate jeopardy has been changed. They also reference a resident was discharged to an unsafe setting or in a manner that placed the resident at risk for serious harm. And they reference a resident still has medical needs, but they cannot be supported in the setting they were discharged to. So a lower level of care, but they still have higher level medical needs as determined by the surveyor's investigation and the chart documentation. So that's what's going to be important for this one. Making sure that you get your ombudsman involved early on when there's an issue, working through the process of discharge, doing a compliance check, so auditing your transfers and discharge, looking at did the physician document and provide a rationale for the discharge if it's something that you're concerned about. Is there evidence that the discharge was discussed with the resident or the representative before the discharge happened? Is there evidence that transfer or discharge was appropriate and that they were sent to a safe location? Is there evidence that the resident is allowed to stay at the facility during an appeal? Were there attempts to meet the resident's discharge needs and were they documented? So document, right? You want to make sure you have all of the documentation in the medical record to show what you've attempted for the resident. An assessment of the resident was completed and the facility is unable to meet his or her needs. So again, documentation of that assessment. Also getting the provider involved too. So the more people involved, the tighter your case will be. Appropriate information was communicated to the receiving healthcare facility. So did we give them paperwork to make sure continuity of care occurs? Did we also call over there and do a handoff report to the staff at the receiving facility? And also document discharge plan is in place and updated as needed. So you want to make sure that you also have the documentation of the plan in place and that everybody's aware of what's happening up front. And educate, 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 right? Notification to the ombudsman, documentation in the record, and then making sure that you get your providers involved in your ombudsman. So lots of work, lots of scrutiny surrounding transfer discharge as well. The next tag is also combining, like I said, some of the information with transfer discharge. This one in particular is a combination of 4, 622, 623, 625, and 661. And they are looking at making sure that the components of the process for transfer discharge of a resident includes what I just was talking about, the documentation and information conveyed to the receiving provider. And so making sure that the notice of transfer discharge is completed. So that's exactly what we had before. Making sure that the notice of the bed hold policy is completed and completing the discharge summary. So you want to make sure that all of that stuff is being done when someone is transferred from your facility. And there's also other guidance regarding information that was conveyed to the receiving facility, the receiving provider, and what that needs to look like. And of course, the bed hold policy discharge summary, which we're all familiar with anyways, is just all in one tag now. The next area is 641, and this is surrounding coding of the MDS. So you want to make sure that, and there's lots of changes to separate for the MDS as well. So you want to make sure that your MDS coordinators are on top of this, bringing the information into any of your clinical meetings, and also ensuring that you have accurate coding for your MDS because they are really focused on the coding of the MDS and making sure that it's all accurate. So I would recommend making sure that if they haven't already, that your MDS coordinators are up to speed on the updates for accuracy of assessment, and that again, you have an audit tool in place to make sure that you're coding that they're coding the MDSs accurately based on the information of the resident in the chart too. The next area is F658. And again, I apologize. This is just a higher level overview. And like I said, if you need more detailed information or recommendations regarding implementation or how you want to tweak your policy and procedure, you can reach out afterwards and we can go over some of that information on an individual basis. The next one is F658, and this is regarding guidance for mental disorders. Its services meet professional standards, but they are referring to mental disorders, insufficient documentation to support mental health diagnosis, specifically referencing schizophrenia, looking at the PASS-R level 1 and PASS-R level 2. And so if all of a sudden the resident had dementia and then maybe 6 months down the road, they find the schizophrenia diagnosis that wasn't listed in the PASS-R to begin with, and they're on antipsychotic or atypical antipsychotic medications, what documentation do you have to support that diagnosis? And so this is really about making sure that you have sufficient documentation to support the mental health diagnosis, and also making sure that you have enough documentation in the medical record that the practitioner who diagnosed based on evidence-based practice, and that there's enough information in the record review. And sometimes you need to pull out interviews as well from family, particularly if you know, the BIM score is low, or you're dealing with somebody who may have some intermittent confusion or something like that. You also want to make sure that whoever was diagnosing, if it wasn't already on the PASS-R, that the provider is following the DSM as a guide for the diagnostic criteria, particularly focus on schizophrenia, schizophreniform, as well as schizoaffective disorder. So For this one, I would definitely start with looking at anybody in your facility who you do have a diagnosis of any of those three. And again, those are schizophrenia, schizophreniform, and schizoaffective disorder. Um, you want to make sure that everything is meet as far as the medication that they're on, diagnosis, past our level 1 and 2. Are we following the recommendations? If we aren't, why aren't we? If there's been any changes, did we send them back in for a new evaluation? And also getting the providers involved, again, making sure that we're doing those compliance checks, making sure the providers have enough documentation regarding, um, the medications that they're on. Are we conducting rounds to ensure that care is being provided as well? Are we doing audits for care planning and making sure that the facility is actually following the plan of care for the residents? And so many changes for this one as well, and that's F658. The next one is F677, and that's the new guidance surrounding ADL care for dependent residents. And I think that kind of coincides with the previous one that I went over as far as the MDS changes. And so there's about a paragraph or two for the guidance for this one. So we want to make sure that the accuracy of the coding of the MDS is also in alignment with the guidance for ADL care for dependent residents. And literally that's what was updated for this tag, are the definitions for all of that. So you want to make sure that your staff are aware, the MDS coordinator is aware, and then I would recommend that everyone receives the education so that when the CNAs are doing their documentation or nursing's doing their documentation, that they're aware of the changes that they need to look at. So the next one is F697, and I apologize, we have 4 minutes, so I'm going to go through the last ones pretty quickly. There's some changes regarding definitions of acute pain, chronic pain, and subacute pain, and also what type of prescribing practitioners need to do to make sure that that pain management is under control and that it's documented. Key elements of noncompliance include providing pain management to not providing pain management to a resident experiencing pain, and also making sure that the pain management program is in accordance with the resident's comprehensive care plan and residents' individual goals for care and preferences. So making sure that you're looking at each individual, their pain, what that looks like for them, how it's being prescribed by the provider, and making sure that they're comfortable, basically. The next one is F757, unnecessary medications. And for this one, they've changed the intent of the guidance. And so the guidance uses terms such as medications and drugs interchangeably. So they've given some of those references about definitions, also definitions for indications for use, and then providing guidance for a comprehensive assessment. Are we initiating a comprehensive assessment, maintaining current practices? Are we looking at risks and benefits? Have we identified the residents' preferences and goals for treatment? Do we have that documentation and evaluation along with a rationale for use in the medical record so that it's spelled out? We need to also be looking at a comprehensive assessment. So when they're admitted to the facility, and this happens a lot, they may come from the hospital with medications and we're not sure where they came from. And so we need to make sure if they are, do they need it? Has it been evaluated? Is the prescribing practitioner looking into it to see if it's justified or not? And then also making sure that if there's a new or worsening change in condition, that we're looking at the medication as well as a possibility of starting that. So we want to make sure if somebody was at home and they weren't on a medication, went to the hospital, and now they're coming to our facility, that we're looking at is the medication appropriate, and making sure that that provider in your building is providing you guys plenty of documentation about why that medication is now justified, even though they were never on it before. The next one that has a ton of changes is F841, expectations for the medical director. So looking at resident care policies and procedures, making sure that they're providing oversight, making sure that they're active in your QA process, making sure that they're in alignment with administrative decisions. Can your medical director speak to your policy and procedure? Should they be interviewed during the survey process? Are they aware of what's going on in the center? So really look over and meet with your medical director, make sure that they are aware of all of the changes of their responsibilities and what that looks like for each person in your centers. F867 is quality assurance, and they reference a framework of health equity. And so CMS also has additional information out there for the health equity framework, promoting cultural and language appropriate services. So how are we talking and communicating about residents' health when their primary language may be something else? What does that look like for them? And how are we incorporating that into our centers to promote culture and language for our residents that may have a different culture or speak, like I said, primarily a different language, even if they do understand English. F880 is basically implementing your enhanced barrier precautions and making sure that your staff are clear on when to implement contact versus when to implement enhanced barrier. And there's additional guidance for MDRO colonization and infection. So make sure your infection preventionists are aware of all the changes for 880, as well as 887, which is the information for COVID-19 immunizations, risk versus benefit, and are we offering the vaccine? What do our policies and procedures look like for that? Making sure we're doing a compliance check that we've offered the vaccine and have the risk versus benefit as well. And the last one, as we're coming to an end because I'm 1 minute over, is 918. And this is just about grandfathering in facilities that may have more than 2 residents per bedroom. And also it gives some guidance regarding 2 conjoined private bedrooms, single occupancy in each room, and a shared bathroom. So that's F918. Those are all the information for all of the tags. I also wanted to let you guys know Granite Peak does offer the 30-minute updates. And next month we will be having a guest speaker for F692 for dietary tag. And so definitely join us for that one as well. Lots of great information from our guest registered dietitian. I'm really looking forward to that one. Anything else? Thank you guys so much for coming. And like I said, for more specifics or information and training, please reach out to us, myself or Kaylee. We have training for each one of the new updates and recommendations for how to implement the new regulatory updates in your facility and how to ensure that you're ready for survey.
Thank you.
Thank you.